Hi there. Did you miss seeing my smiling face in your lectures? I hope so. I've been playing around a little bit and trying to figure out how to best do this camera without covering up everything on the screen, so we'll try it this way and see. Today's lecture is going to talk about pulmonary ventilation. And pulmonary ventilation is just breathing. But you can see there's an awful lot of factors that come into play here. So we're going to first start talking about pressure relationships in the thoracic cavity. Now, air, just like blood, is going to move from an area of high pressure to an area of low pressure. And so we need to look at these pressures when we start going through volumes. So there's three pressures we look at. There's atmospheric pressure. And atmospheric pressure is the pressure all around you right now, pushing on your body. And so it's about 760 millimeters of mercury. We're using the number that it would be at sea level because Maryland is pretty close to sea level. Now, you probably know that when you dive, if you were to jump into the deep end of a swimming pool and go very deep, that pressure increases. In fact, you can feel it pushing on you. It might hurt your ears. So as we go deeper and dive at the ocean or swimming pool, this pressure actually goes up. But if we go up in altitude, if you go climb a mountain, as we go higher and higher in elevation, this pressure actually decreases. This is why people will say the air is thinner. The atmospheric pressure is actually lower as you go up in altitude. Now, when we actually look inside the lungs, there's a pressure called intrapulmonary pressure. Intra means within. So this is the pressure actually inside the lungs. So we say P, pull. And notice this pressure varies. It ranges anywhere from 758 to 762, and it depends on the volume of your thoracic cavity. Now, you might remember that diaphragm can change. It can flatten out or recoil. And as it does that will change the volume. And we'll get to that shortly. The intrapleural pressure is the pressure inside the pleural cavity. Now, real quick review, we have the visceral pleura that actually surrounds and attaches, right, to each lung itself. And then we're going to have the parietal pleura, which is going to line the cavity. So that one would be out here, lining the pleural cavity. And the space is the actual pleural cavity, and that's that little space in there. Well, that space has a pressure that's always negative. And what that means is it's always less than 760 millimeters of mercury. So it's usually 756 or even lower. So why is it negative? Well, it's negative because this little area here, you have a visceral pleura and you have a parietal pleura, and the visceral is very, very elastic. The lung is very elastic, so it's always pulling away from the parietal, and as it pulls away, it makes the volume a little bigger and it drops that pressure in there. Now, a couple things to define here. Whenever you hear me say negative pressure, or if I say -2, or we say +2, that's always in reference to atmospheric pressure. So a -2 literally means 758. You take 2 away. If I say +2, it's 762. So it's just another way that might be used to explain these numbers. Now, notice again that we said they're going to change a little bit. And they're going to change based on the movement of the diaphragm. But remember, anytime the pressure is equal inside the lung and outside of your body, there's no movement of air. Air will move from a higher pressure to a lower pressure until equilibrium is reached. Now, when we look at this pressure here, when we look at this intrapleural pressure, it's pretty important that it's negative. Because what it does is it helps keep the visceral pleura attached to the parietal pleura. It actually causes a little bit like suction of this. And so if we go back to this picture, we have atmospheric pressure pushing, right, against us. Now remember, I'll put these X's here. That's where it's negative. And so we have atmospheric pressure pushing against it. And then we have our intrapulmonary, right, which is also greater. So we have these two pressures in and out are greater pushing against that negative space. And what that does is it helps hold that visceral pleura against the parietal pleura. Now, if anything disrupts this, if you have any kind of opening or any kind of trauma, then what happens is the air rushes in or the air rushes out, and now it's equal. Well, when it's equal, the lungs collapse immediately. And you can see the term for a lung collapse or collapsed lung is atelectasis. So it's very important to maintain these. Well, what kinds of things could do this? Well, if you get air in there, it's called a pneumothorax. We are not going over all the causes, but there's different things that could happen that could open up and again cause the air to move. Or you could have trauma that causes a hemothorax, and that's when you have blood in the space. So if your lung collapses, you're going to have very severe signs and symptoms. It'll hurt really bad. You'll have shortness of breath. It's not going to be that type of situation where like, I wonder if my lung just collapsed. You will know. So what do you have to do? Well, you got to get a chest tube. And what that chest tube does is they put it in there and then they suck all the air out and make that space negative again. And when it's negative, the visceral inflates. And now it's going to basically be an inflated lung and out towards the parietal. And sometimes they leave those tubes in for a while until the area has healed. Another way that pressure is measured is there's other units. So I will use millimeters of mercury. However, you may have seen torr before. So 1 torr is 700, actually 1 millimeter mercury is basically a torr. It's used more in respiratory therapists. I won't be using torr. Centimeters of water, you might see this in the hospitals. And if you buy any kind of gas, you would see it as PSI. So just be aware there's other units when we talk about gas pressure, but we'll use mmHg. Okay, so those are the pressures. So what's the relationship with pressure and volume? Well, we already said air flows from high to low pressure. So how do we change those pressures? We change the volume. So there's a law you've learned called Boyle's Law. And Boyle's Law says when the temperature is constant, which it is in our bodies, the pressure of a gas is inversely related to the volume. So what that means, if we look at this picture here, these little black dots are gas molecules. So gas pressure is gas molecules just like colliding and bumping into each other. So you can see that if you decrease the area, those molecules are going to hit a lot more, so the pressure goes up. If I increase the volume, now there's fewer collisions, so the pressure falls. So we have an inverse relationship. Anytime the volume of the thoracic cage goes up, the pressure will fall. And so every time we have the volume decrease, then we know that in that case, the pressure is going to go up. So we come back to, what's changing the volume? Well, it's the diaphragm. So when we look at a respiratory cycle, it's an inspiration and an expiration, or you can say inhalation and exhalation. You learned a cardiac cycle, the events basically through one heartbeat. Respiratory cycle are the events that happen for us to inhale and exhale. So inhalation or inspiration is always active because it requires the diaphragm to contract. So a nerve impulse has to come down to the diaphragm. You might remember it gets there through the phrenic nerve. And when it goes through the phrenic nerve and innervates the diaphragm, that makes the diaphragm contract. So normally it's this dome-shaped muscle, and when it contracts, it flattens out. So that's why it's called active. Expiration or exhalation is passive because basically the phrenic nerve just stops sending any information to the diaphragm. Well, when a muscle doesn't get a nerve impulse, it relaxes. So it's dome-shaped when it's it's flattened out when it's contracted, and then it returns to that dome shape. And so that's relaxation. The muscle's relaxing. And the lungs are so elastic that if you stretch them, they immediately recoil like a rubber band. So we're going to be looking more at this diaphragm change. So again, if we look at this picture, notice here we'll do diaphragm relaxed. And I'm just going to try to draw a simple line here to show the volume. So we'll draw like this. So that's my volume right here when it's relaxed. Now it's going to flatten out and contract. Having some issues with my different pens right now. So notice now that when the diaphragm contracts, let's make this really big. Notice what happens to the volume. And remember that volume changes are going to lead to pressure changes, which will lead to air moving. And so when the diaphragm's relaxed, the volume is small, right? So the pressure is going to be higher. And when it contracts, the volume goes up, so the pressure is going to fall. So if we look at this in more detail, we have the events that occur for inspiration. And what we're looking at is the diaphragm contracts. When it contracts and it flattens out, we just said the volume increases. Well, the volume goes up, the pressure goes down. That's what makes intrapulmonary pressure decreased. It's usually 758, 759, not very much. But now the pressure in your lungs is less than the pressure outside of your body, and so the air is going to flow in. Now the air will only flow in until it reaches equilibrium. So it'll flow from 760 and it'll come in. And as it comes in, right, the pressure in your lungs is coming up because air is entering. And so it enters until they're both 760 and then there's no movement of air. And if you kind of pay attention to your breathing, and sometimes when we focus on it, we change it, but you'll notice that inspiration is the longer phase, roughly 3 seconds. And then notice you inhale and there's a brief pause. That pause is when the volumes are the same, and then you're going to go into the factors for exhalation. Now, just know, though, that it is better to breathe through your nose than your mouth. Our nose has all the mucus, it has the concave, the meatuses, really important for moistening the air, right? Humidifying it, warming it, filtering it. When you breathe through your nose, you actually activate your diaphragm a lot more than through your mouth. So you're activating your muscles. And when you do that, you're getting more oxygen in your blood. So breathing through your nose is much better for oxygen uptake as well. So, if you breathe through your mouth a lot, that's not good. For one thing, you probably get a sore throat. You ever have like a sinus thing and you're breathing through your mouth all night? It's hard to sleep. Your mouth and your throat get all dried out. So I just wanted to mention that. So what if you want to take a deeper breath? So, right, we can always take a deeper breath. Well, those are the accessory muscles. And the ones that help are called the external intercostals. Remember, they're between the ribs and they lift the ribs up. And then you have the scalenes in the neck. Now, the scalenes are usually only used for extreme, like respiratory distress, trying to make my pop out and to help you breathe. So what's going on here? Well, we have our diaphragm, right? So when our diaphragm flattens out, we get a big change in volume, which is awesome, right? And we drop, let's just pretend 758. And so air rushes in from 760 to 758 until it reaches 760 and air stops moving. What if I could really change the volume even more? What if I lift my rib cage more? Maybe now I'm able to drop it down to 757, 756. Well, that's going to allow more air to come in because it's going to take more air to change the pressure from 756 to 760. So whenever we take deeper breaths, we rely on our accessory muscles because they cause a greater volume change, which causes a steeper pressure difference, which allows more air to move. Now, exhalation is passive. So remember, the phrenic nerve stops depolarizing the diaphragm, and now the diaphragm relaxes. So it goes back to that dome-shaped area. Well, when it comes back up, now the thoracic cavity volume goes down, which means pressure goes up. Now my intrapulmonary pressure goes up. Now it's greater than atmospheric, so air flows out. So our normal quiet breathing, we call it diaphragmatic breathing, we're just moving air in and out. But what if you want to blow more air? What if you're blowing out birthday candles, right? Or if you're just sitting here and you exhale, you can always, right? You should try it. You can squeeze more air out. We don't breathe like that, right? That would be weird. But so there's always air left in there. So if we want to try to get that out, we would use our internal intercostals. Remember, they're pulling the rib cage down. And then try it, you use your abs. And so those are going to be the accessory muscles for exhalation to help with that process. Now, when we're looking at this, by the way, when we're looking at this whole passive, I mentioned the lung recoil. And there's a little blank in your notes, so make sure you write that because the diaphragm does relax, but the lungs recoil. So when you stretch them, they always go back to their smallest size, like a rubber band. And that's very, very important for expiration. If we lose our ability for our lungs to recoil, then that's a big problem. That's a lot of pulmonary diseases. So here's your cardiac cycle. We know our inspiration, right? The diaphragm is going to contract. The volume is going to increase. The pressure falls. Air flows in. And you have a pause. That pause, where there's no air movement, is brief, but we're at equilibrium. Then when the diaphragm relaxes and the lungs recoil, the pressure goes up, air flows out, And there's a pause because we don't breathe like that, right? You breathe in, you usually inhale for about 3 seconds, pause, exhale for about 2 seconds, and there's always a pause when we're at equilibrium, and then the phrenic nerve turns on again, and we just keep doing this cycle. So if we look at this view, you can see the pressure changes. For inhalation, the pressure falls. We're looking inside the lungs, intrapulmonary and the alveoli. It decreases, and exhalation, it goes up. And it's not much of a change at all, 1 to 2 millimeters of mercury. Now, just a note, intrapleural is always negative, remember. It just becomes more and more negative. So, its purpose is just to keep the membranes together, keep your lungs inflated. But notice as we move, this is volume. We actually move air in and out with breathing. The amount of air we move in and out is called a tidal volume. So sometimes we just say TV, or sometimes you write it that way. But this normal breathing in and out, we're going to use the magic number of 500 ml. So that's the amount of air you move in and out. Now, this depends on your body size. So if you're a really big person, you might move 600. If you're a real small person, it might only be 400. But that's called a tidal volume, and that's the amount of air that's moved. So we're going to move on now and talk about some pulmonary volumes. We will look at this more in lab, but these are the ones I want you to know for this exam. So we mentioned already this anatomical dead space. Remember, that's the air that's in the conducting zone, and it never gets down into the respiratory zone. So it never participates in gas exchange. It's just filling up the tubes. And we know that that's about 150 ml. So if you're moving 500 mLs in, 150 of that never makes it to your lungs. And so there's two types of things we look at. There's something called minute ventilation, which is called respiratory minute ventilation, and they usually use a V and an E. And then there's alveolar ventilation rate. And so these are kind of the respiratory counterpart to cardiac output. When we looked at cardiac output, like how much blood was leaving the heart per minute, we had to know how many times it beat and how much blood, right, got squeezed out each stroke volume. Well, minute ventilation, same idea. We have to know how many times are you breathing, your respiratory rate, and you multiply that by the air that moves, your tidal volume. So a normal respiratory rate is usually 12 to 20 breaths per minute. And so we usually use 6 liters per minute for that. So 6 liters of air in and out. But what might be more important is how much of that actually is available for gas exchange. How much of that can we actually get in our blood and move? So that's our alveolar ventilation rate. So that still uses your respiratory rate, but now you take into account the dead space. So you would take your 500, but you would subtract the 150 that never makes it to the lungs. So you would multiply that by about 350. Now, there's different conditions that can cause an increase in dead space, and there's ways of measuring the dead space, but that's beyond this course. So when you do that math, you're going to get about 4.2 liters per minute. So what that means is you're moving 6 liters in and out, but of that per minute, 4.2 liters is actually going down in your lungs for gas exchange. There's a few other lung volumes I'd like you to know right now. So in your notes, you can see we already talked about tidal volume, the amount of air we move in and out normally. I want to come to this ERV. So again, if you're just sitting here, you could just push air out. So ERV is the amount of air. It's in your lungs after a normal exhalation, but you could get it out if you wanted to, like blowing out birthday candles. So that's the amount of air that's in there, but it could be exhaled. And you'll say around 1200. Now, residual volume, though, you can see here, residual volume is in your lungs and you could never get it out. It'll never leave. So it's always stuck in your lungs. In fact, it keeps your lungs inflated. A lot of times if someone drowns, they'll be floating at first, and that's because of the air in the lungs from the residual volume at first. So that you can never get out. Now, if you see a capacity, there's a few here, but a capacity is 2 or more volumes added together. So the one we're looking at right now is FRC. And FRC is called functional residual capacity. And this is the amount of air that's in your lungs right now every time you exhale. So you're breathing normal, and every time you exhale, that air didn't come out. So we usually say that a residual volume is around 1200, and we say an ERV is around 1200, which means that every time you exhale, there's about 2.5 liters of air still stuck inside your lungs. And so our FRC is a really good measure of our lung recoil. And we talked a little bit about that's so critical for exhalation and getting air out. So if we see an increase in an FRC, then we're knowing something's wrong. Something's going on with the elasticity of the lungs and the recoil. And you see that a lot in COPD, like bronchitis and asthma. Okay, so now we are on to physical factors for ventilation. So we just need to talk about a few things that affect our breathing. So one is the resistance. We've looked at this before. We know that we have resistance to flow. We know the conducting tube isn't a big deal because there's all that hyaline cartilage, right? The conducting zone has the hyaline cartilage. It keeps the tubes open, the airways open. But when we get down into the bronchioles and the smaller ones, they have a lot of smooth muscle. And we know the smooth muscle can bronchoconstrict or dilate. So you've seen this before, F equals P over R. Well, now we're looking at flow, we're thinking of airflow. So if your resistance were to go up, right, what's gonna happen? Well, to flow. Well, in the heart, when resistance went up and we wanted to maintain flow, the heart had to just work harder and harder, right, and generate more pressure, and our blood pressure went up. But we don't have a pump for air. Now, if you go on a ventilator, you do, right? They have positive airway, positive pressure machines that force air in to overcome that resistance. Those are pressure. That's why they're doing that. But right now we don't have that. So if our resistance goes up, then what's going to happen now is our flow is going to go down, right? So resistance will directly lower our airflow. And that's not good. So again, the way you overcome it is you go on some kind of ventilator or positive pressure, but the quickest way to do it is to try to bronchodilate those airways. So if you can open them up, now you can drop the resistance and you restore airflow. That's why you have bronchodilators. That's what, a lot of times for asthma, when you're breathing that in, you're trying to basically allow that smooth muscle to relax. And so when we look at this, let me go back here. We know already that we talked about norepinephrine, right, is going to be a bronchodilator when we look at norepinephrine. And you might remember that norepinephrine is going to bind to that beta-2 receptor. Things that would increase resistance, well, we know acetylcholine could, but when we're looking at, things that could cause resistance that might try to plug this up, we're looking more at like inflammation. Maybe the bronchioles are inflamed and swollen. That's going to constrict. You can have excess mucus in there. You could have tumors. So those are more of the common disease sources, basically, of resistance. Another thing we know is we need to make sure that our alveoli are nice and open. When we are born and we take our first few breaths, they all open up, but we want to keep them inflated, and that's what surfactant does. So if something should get rid of surfactant, like chemical inhalation, smoke inhalation, then what's going to happen is those alveoli are going to collapse. And when they collapse, you can't ventilate. You can't move air very well. There's something called compliance. Compliance is how easily they open. So our lungs are very compliant. They can open and expand pretty easily. So I put this picture in here of the balloons because if you've ever, blown up a balloon, at first, it's really, really hard. But then once you've done it a few times, once you've had a few breaths, it opens a lot easier. If you heard that, that's my dog. I apologize. So anything that could affect this, right, make it harder for them to inflate. Again, if there's more surface tension in the alveoli, definitely, right? Distensibility. Maybe you have, distensibility is how easily, basically stretching. Maybe you have scar tissue. Or tumors and they can't move very well. Or maybe your lungs are fine, but your thoracic cage, you have a broken rib, you have scoliosis, so you can't ventilate that way. And we're just going to wrap up talking about some breathing types. First of all, eupnea is our normal respiratory rate, and I'm just going to make this 12 to 20 breaths per minute because that's probably what you're going to see more often. So if you were to time your breathing, so inspiration and expiration is one cycle, remember, that it should be between 18 and 20. And so you have this table in here with some different terms. So dyspnea is difficulty breathing, shortness of breath. It might feel really hard to breathe, like there's pressure on your chest. The orthopnea is difficulty lying down. You might have remembered of orthostatic hypotension, ortho like body position. So when you're lying supine, when you're lying down, it might be more difficult to breathe. Now, if you look in your notes, you say, bradypnea and tachypnea. And so these should look a little familiar when we talk about bradycardia and tachycardia. So this is basically brady means slow. So if you're breathing too slowly, less than 12 breaths per minute, and that would tie right in with what's called hypoventilation. So if you're hypoventilating, you're not getting air in. You're probably hypoxic. So it's usually due to having very slow breaths. So you would have the bradypnea, and usually your tidal volume is lower, so it's restricted. So like, opioids can do this to you, like morphine, sleeping aids. There's things, alcohol can kind of hypoventilate. Now, if we have a faster than normal rate, so we're breathing faster than 20 breaths per minute, tachypnea, then that would go with hyperventilation, where we have a faster respiratory rate. But hyperventilation, you also usually move more air as well. And when we have hyperventilation, we're going to see shortly, we're really going to worry about our CO2 levels in our blood, because when you hyperventilate, you're blowing all that CO2 off. And interestingly, when your CO2 levels in your blood fall, your blood vessels, your cerebral vessels to your brain constrict. So now blood doesn't get to your brain and you get lightheaded and you pass out. And that's why that might happen. And then the last one you notice is apnea, and you probably know what apnea is. So A means without. So this is absence of breathing. So, this sometimes happens during sleep. People have sleep apnea, and so they will actually stop breathing momentarily during the night. So my husband actually has sleep apnea, and I found, though, that it goes away completely as soon as I take the pillow off his face. So I'll leave you on that one today.